think we just went live, I hope. Hello, everyone. Welcome to our program, Inside the OR. I'm Dr. Karra, the Director of Veterinary Services, and I have some of our other veterinary staff here with us today, and I'm going to host this program, but we'll start by introducing everyone. So as you know, I'm Dr. Karra. I'm the Director of Veterinary Services here at the Wildlife Center, and I oversee our medical and rehabilitation programs. With me, I have...
I'm Dr. Natalie. I'm one of the veterinary interns that is here for the 2024-2025 year.
And then we also have with us two of our licensed veterinary technicians, Jess and Rachel. I will let them introduce themselves now. Rachel and Jess, do you want to let us know how long you've been here as well, and what your role is?
Sure. So my name is Jess. I am the LVT supervisor. I started back in 2018 as the LVT intern, and I've just been here ever since.
Hi, I'm Rachel. I have been an LVT here full time for about 3 years, but I actually started as a volunteer while I was in tech school.
Great. And then we also have Dr. Olivia joining us. Do you want to introduce yourself, Dr. Olivia?
Yeah, I'm Dr. Olivia, as Karra said. I'm the research fellow, and I've been here for 2.5 years now. First, I was an intern, then I was the senior intern, and now I'm the fellow.
Perfect. Thank you, everyone. I guess I didn't answer the same things about myself. I've been here over 6 years now, and I was an intern, and then a senior intern, and then a research fellow before I became the director. So what you're joining us for today is a program talking about some of our surgical procedures, some of our favorite surgical patients. But to start with, it says, I think the program's called like From the OR or In the OR. And I think it's very funny. Dr. Natalie and I are actually we're broadcasting to you from our surgery room today, which we thought would be fun for this program, but also, all the other offices were in use. So we were like, great, perfect. This will be really representative. So we are actually in our surgery room here today. And I thought we would kind of tell you a bit about what we have in this room, the things we have in this room, and then talk a little bit more about what we do in here. So I think we have a good photo we can share. So for context, we're sitting at that silver table you can see there right now, Dr. Natalie and I. And this is our surgical suite. This is one of the busiest rooms in our hospital. If you had a tour of the Wildlife Center, you've certainly walked by and seen it. And what I think is really interesting about this is you'll notice this is a clear glass window looking into the operating room we're in here. And that's because we're a teaching hospital. It looks like a big room, but it fills up pretty quickly. So if we have students who are wanting to watch the procedure or anything like that, they're able to stand out front there, watch what we're doing, and we can be in here doing the surgery. We're very fortunate that our operating room has a lot of really fun, cool and useful medical equipment in it that so many of our wonderful donors have helped us purchase. So if you are a longer time follower of the Wildlife Center, you'll know we fundraised a couple galas ago for our fluoroscope, which is in the corner there under that blue drape. What that is basically a X-ray machine that is like a movie, which is really cool. So you can see things move in real time. So we love that. We have tons of other really important equipment in here. Most importantly, this beautiful table that I'm sitting on, I can demonstrate. It goes up and down with the push of the button. So there we go. So we can move that up and down to do surgical procedures and also accommodate people of all different heights, because we have some shorter surgeons on our team and some taller surgeons like Dr. Olivia on our team. We also have a lot of really important equipment for anesthesia, and I'm going to have our technicians tell us a little bit about anesthesia and what we do in surgery shortly here. And I don't know that I can see if people have any questions. I'm just realizing, but we'll get back to that after, I guess, if you can think of that. That's the kind of general overview of our actual operating room. And we have, supplies for every surgery you could imagine in that cupboard there that is expertly organized by our technicians. Everything is exactly where it's supposed to be with all the right labels, which is very, very wonderful. So moving on to, where we do surgery, the next thing to kind of talk about is why do we do surgery? What are we capable of doing here? And I kind of think of two big categories of surgery we do a lot of. We do a lot of orthopedic surgery, and a lot of ocular surgery. So I guess I'll ask Dr. Olivia, Olivia, what do you feel are the most common procedures you have performed within this room?
Oh, I've definitely done a lot of owl eviscerations, taking their eye out. That's probably the most common one, closely followed by turtle leg amputations. Do a lot of those. And then, of course, bird orthopedics, lots of those.
Yeah, so we do a lot of orthopedic repairs. I think we have some pictures that we'll share shortly here of a fixator that we've put on a bird. So basically what happens is when that bone is broken, we need to go in and stabilize it with pins and wires. And then those are often going to be extending externally outside the bird connected to a bar. I think we have a photo of that. It's like a purple looking bar on a bird leg that hopefully we can bring up here. A little bit, I think it was previous to this. It was the leg of a bird. A little bit previous. There we go. Okay, perfect. Thank you. So what we can see here is this is a fixator that we've put on this bird that has a broken leg. So underneath that purple tape you see there is a bar. And then actually, if you look really closely, running right through the bird's leg is a bar, a pin. So a pin is going skewering right through the leg and then attaching to the bar on either side. So that's a really, really common procedure we do on especially our avian patients. And there are special techniques to repair every different bone, depending on the fracture, depending on the type of bird. So that's something we do really, really commonly. And then I also think we have, if we go to the next, I think we have an owl evisceration example. So here's Dr. Olivia performing an evisceration on a screech owl. Olivia, why would we perform an evisceration?
Generally, if there's a lot of trauma to the eye, so usually these owls are hit by cars, and their retina is destroyed, so the eye is non-visual, and usually it will cause chronic pain if we leave it. So we take it, since owls rely mostly on their sense of hearing versus sight. It's safe to take an eye and still release them.
Yeah, and they do really well, honestly, with one eye. After the surgery and they're healed and everything, they'll go through what we call mouse school to make sure they can still hunt and fly, even missing that eye. And they do just as well as their two-eyed friends usually. So that's a really common surgery we did. I think that's the first surgery I ever did here when I first came to work here. And it's a very fun procedure. And something I love about this procedure is we actually will often have our students learn how to do it as well. We'll put them through labs to learn this procedure while they're here with us. We'll sometimes, for some students, even let them do this procedure. And I think that's really impactful because they can then, go out into the world, go out into practice, and know how to do a really basic surgery like this. So it's very, very helpful, and a really fun surgery to perform, I think, personally. Okay, so moving on to what types of surgeries we do, to a little bit more about how do we accomplish this. These are wild animals. We can't ask them to sit still or anything like that. And really that is accomplished through our technicians helping us run anesthesia for our patients. So I'm going to pass it over to Jess and Rachel to talk a little bit about the role of the LVTs in surgery. How do you get from, the patient being in the cage to being ready on the operating table for us? And then we'll talk a bit more after as well about some more preoperative care that we have to do.
Yes. So basically surgery, I like to think of it in terms of like a three-part orchestrated event. There's the pre-operation that happens, and that's essentially when we're getting the patients ready for whatever surgery they're about to have. So we, get the surgical site prepped. We sometimes will place catheters in our patients, and essentially we're just kind of getting those patients primed for the big procedure ahead. And then there's the actual surgical event that's happening, which sometimes is, orthopedic procedure. Sometimes it's an evisceration or an amputation in our cases of reptiles. And then then there's the post-op period. And a lot of times the post-op period is honestly the most dangerous for our patients, especially if they've been under anesthesia for a long period of time. If any of our viewers have ever had, any sort of anesthesia or surgery, that, coming out of anesthesia can sometimes be a very rough experience. And you're groggy and cold and, can't really thermoregulate. And our patients experience the exact same thing. And so we try very hard as best we can, to keep them, warm and comfortable and try to, regulate all of those, bodily things that they can't maintain when they're under anesthesia. So it is kind of like a big process because, in terms of getting prepared for the surgeries that we do have, a lot goes into that. We do a lot of preparation ahead of time. But unfortunately for us, we don't really know, on any given day, what's going to walk through the door. So, we don't know what surgeries we might have that week. So it is kind of a guessing game. So we just kind of have to keep all of our supplies ready and on hand, for any given scenario. So this photo that you're seeing on your screen right now is actually of a bear cub that came in a couple years ago. That had I think it was a fracture that was really close to the elbow. So we actually had to bring this bear cub to another facility because we don't do a lot of mammal orthopedic procedures. So this was an example of where we collaborated with another facility that was willing to kind of share their expertise. But sort of the same things kind of went into that. A lot of preparation in terms of, we do all the same sorts of things for the prep. We intubate them, place an IV catheter, prep the surgical site by shaving and cleaning wherever, those pins are going to be. And then post-operatively, it's very similar to a cat or a dog where, we're just trying to keep them warm, provide any post-op pain management, and, replace any fluids from blood loss or that type of thing. So.
Awesome. Thank you.
Yeah.
And then Rachel, a question I have for you, if we could elaborate on a little bit. So Jess did a really great job explaining what happens before anesthesia, kind of after anesthesia. During the actual procedure, while we're doing surgery, what types of things are you monitoring for, and how, what is your role at that point in time?
Yeah, so really, we have a very important role of keeping the patient alive while the doctors are doing their thing. So we're going to be, oftentimes with birds, we're going to be breathing for the patient the whole time. They'll be hooked up to like an anesthetic circuit that will have like a bag that we can squeeze to breathe for the bird. We'll be monitoring their heart rate. We'll usually have them hooked up to an EKG. So, when you think of like in the hospital, you see like the lines of the heart rate. So we'll have a screen that will show that as well. We can monitor, yeah, so those are the big things for birds, really. For reptiles, it's harder. We'll usually use something called a Doppler, which actually you can hear the heart rate basically using the Doppler. So that's kind of neat. And also during that time, we'll be helping the doctor, like assisting them, like opening like packs, helping get the drill set up, for example, getting them any supplies they might need that we may not have gone out. So it's a lot.
Yeah, it is a lot. And that's exactly the point. Our technicians truly have to keep the patient alive while we're performing the surgery, but also asleep. I used to have an anesthesiology professor tell us that anesthesia is the closest you take your patient to death without actually, going all the way. That's kind of what it is, right? They're unconscious. And our technicians really also have to make sure that they're deep enough under anesthesia that they're not going to feel anything we're doing, they're not going to move, but also that they're not so deep that they can't continue, having their heartbeat and all those types of things. So it's a very careful balancing act of not too little, not too much. It's very much a Goldilocks kind of situation. And they're, sometimes turning up the anesthesia, sometimes turning down the anesthesia, sometimes giving additional medications. So it's really, really important. And they do a really great job of monitoring them and letting us know how the patient's doing and if we need to go faster or anything like that. So that's kind of the anesthesia. One other thing I wanted to talk briefly about too is just the diagnostic tools we have to use in and around surgery, and our technicians are really involved there as well. So we're often doing radiographs or x-rays before we're going into surgery. So there's an example of that there. That's an x-ray of one of our patients there. We also are doing a lot of blood work before surgery to make sure our patients are stable. Jess and Rachel, do y'all have anything to add about, what type of diagnostics we might be able to do to assess if our patient is stable for surgery, and things we try to do beforehand?
Yeah, I would say I think that the preliminary blood work, it's not feasible in every single patient. Sometimes, the injuries that they come in with are, it's really, really urgent to get them to surgery. And so sometimes we don't have the luxury of getting blood work on them before we take them to surgery. But in most cases, even just like a baseline, PCV and total protein is enough to tell us whether or not our patient is anemic, or, has a really low total protein. And that can give us a really good foundation of information about whether or not we should be really trying to get, prioritizing an IV catheter in our patient, or, if they're going to be at a greater anesthetic risk, which will kind of help us in the prep phase before surgery.
That being said, a lot of our patients aren't great surgical candidates, anesthetic candidates. So yeah, they're not usually, sometimes they're coming in and having sustained trauma or blood loss or all sorts of things that put them in a higher risk category than like a healthy patient.
Exactly. And getting these things kind of beforehand can help us know, what can we do to try to mitigate any of that risk. That being said, it's a really good point Rachel brings up. These are animals who come in a lot of time and sustain pretty serious trauma. And in an ideal world, you would stabilize them, wait a while before you can do the surgery. But in some of these instances, we do that. We'll stabilize them as much as we can. But sometimes if they have a fracture that's open, our chance to fix that, our window to repair that, is pretty small. So it's a balancing act of getting in here as soon as we can, but not going in before the patient might not survive. So it is very challenging to kind of strike that balance. So great. No, that's very helpful. Thank you. Actually, can we bring that slide back up for one more second? I'm so sorry. I was just going to see if Jess and Rachel could tell us what they were seeing on the slide. What are all these? What are these images? The radiograph is pretty self-explanatory, but what do we have in the middle? And then what's all the purple polka dots?
Yeah, so the image in the middle, that's the same blood smear essentially. So the image on the left is unstained. The image on the right is the same slide, but it's stained. And then the image all the way to the right is actually what it looks like under the microscope. So that's a blood smear of actually a bird patient. So all of the pink and purple cells that you're seeing kind of all around in the background, those are red blood cells. So in birds and reptiles, they're nucleated. And then that larger pink cell that you're seeing in the center there, that's a heterophil in an avian patient.
Which is the heterophil is a type of cell used for like inflammation and inflammatory response and things like that. So something we see commonly, unfortunately, in our very traumatized patients.
Yeah.
Great. Okay. So that's kind of just some background to, what we do in surgery, why we do surgery here, how we do it, all those types of things. But I know people probably want to hear about some of our interesting patients that we've had in our surgical suite. And I'm just going to see if I could pull up the YouTube so I can try to see if there's any questions. I'll try to do that in a second. I'm worried it'll make terrible feedback, but we'll see. So moving on to just talking about some of the patients and what are the stories that have come through this room. The first patient I want to talk about is one that we had for quite a long time. And this patient left not that long ago. And this was a great blue heron number 240361. And I love this heron story. I love that it started with Dr. Natalie, not this Dr. Natalie, but one Dr. Natalie ago. We like to always make sure we have at least one Dr. Natalie. Too. So previous Dr. Natalie, our intern from last year, actually went out and rescued this bird from the wild, right up the street from my house, incidentally. So I also feel deeply connected to this bird because I do feel like it's probably the heron that I see in my backyard, hunting in my creek. So lots of connections to this bird, the whole way along, which is really, really interesting. But I know I wasn't actually here the day the heron came in. It was Dr. Olivia and Dr. Natalie, I believe. Olivia, do you want to tell us a little bit about this patient on presentation, and what you kind of did and what you found?
Yeah, absolutely. I just remember that day Natalie was off and she had her family visiting and they went to rescue the heron together. And she came storming down the hallway and she was like, "It's so bad. It's so terrible. It's not going to be good." So I already thought, I was like, "Oh, great. This heron's going to suck." But then I had the students that I was with that day look at the heron and they're like, "I think it's actually a good fracture," which never happens for herons. Usually when they come to us, they're in really horrible condition. They're generally really hard to catch until they're wasting away and dying. But this guy was actually in very good body condition. He was very feisty. I made sure the students were all wearing the appropriate PPE and wearing goggles. And I palpated his wing and he definitely had a metacarpal fracture, but it seemed pretty new, which again is very rare for our heron patients. So we took radiographs and you can see down in that corner, that's his initial radiograph from admit, and you can see his fracture kind of at the end of his wing near his wrist. And I was still kind of apprehensive at that point because generally heron patients don't do very well. They have a lot of complications related to stress of being in captivity. So I was a little concerned about that, but I told the students if we really wanted to try, we could go for it. We bandaged up his wing and prepped him with a lot of pain meds and some antibiotics for the next day to plan for surgery. And again, I was pretty apprehensive, but at that point I told the students, okay, we got to be really serious about this patient. He's high stress. We have to be absolutely silent in the room. Like no one can talk at all. I was really strict with the noise levels the weeks he was here. The students, I don't think, appreciated me telling them to be quiet all the time, but I was like, gotta save him now. We're going for it. So the next day we moved on to surgery. He was, again, pretty stable to begin with. And I believe Jen, our previous LVT intern, ran anesthesia for me, and she was not super excited about it. But she did a great job. And the picture of the heron there, that's him being prepped for surgery the following day. And you can kind of see his little wing peeking out below his head.
I had these photos open on my computer and Jen walked by and she was like, "Wow, that's a great tape job," to the tape all over his beak because she did it. And for those who, don't do a lot of surgery, you can actually see in the photo, there's a tube going into that heron's mouth. And that's taped in and that's into his respiratory tract, basically. So that's how we're delivering that gas anesthetic and also making sure we can make sure they keep breathing during surgery. So we call that intubation, but basically you would, the same would happen to you if you were to go under general anesthesia for surgery. And we do that for pretty much all of our patients when they're going under anesthesia. So very, very cool start to this story for sure. How did the surgery go, Olivia? How did you feel like it went?
Yeah, so this was my second ever metacarpal fracture repair. My first one was a red-shouldered hawk, which is much smaller. So this one had a nice big bone for me to work with. I was a little apprehensive because it was only my second one, but I did it and I think it went really well. I placed bigger pins than I've ever placed in a small bone. And this was one of my first surgeries where I was like really feeling confident with my orthopedic skills. And the fracture was like a couple days old, so it was a little bit hard to place perfectly back together. But this patient was super stable the whole time. Jen did a great job keeping him alive, but keeping him deep. And yeah, he recovered very well right after surgery. These pictures are of him in recovery. We kept him connected to IV fluids for a couple of days just to make sure that he would stay stable, just for blood loss reasons, because he's pretty bruised. But overall, yeah, the surgery went very well. That's me placing some of his pins. I ended up placing 5 pins to stabilize his fracture, and then we put on an acrylic bar afterwards, which you can see is covered in the colorful pink vet wrap. We kept him in a body wrap for a while just because his wings are so long and it's on the end of his wing. We were worried the fixator might be a little heavy and put unnecessary force on his wing. But yeah.
Yeah, no, the post-op rads look excellent and it went really well. And you'll see in that photo there, it's kind of bright with the light, but what Dr. Olivia has in her hand there is a surgical drill. It's in the cupboard behind us here, but we have a drill that we use just for surgery, and it's a surgical drill. It's not like a drill you would buy at Home Depot, and because it has to be sterile for surgery. So this drill can go through our autoclave, which sterilizes it to make sure there's no bacteria or anything like that on it, because we don't want there to be any sort of infection. So that's one of the really cool things we have here. And actually this photo also, just to tie into what Rachel was saying earlier, you can see our surgical monitoring machine in the back with the ECG, those lines running, and you can see this heron's heart rate was 182. So just interesting things that you can see in this photo. Yeah, so this patient, the surgery went well. I think we were still all kind of nervous that something could go wrong. Herons, they're big, awkward birds. They're not really great in captivity. And as Dr. Olivia mentioned, they're very stressy. They're subject to things like capture myopathy, potentially, which is basically just stress overwhelming your system whenever you're captured. And we had to capture this bird every week to do repeat radiographs and sometimes daily to give medication. So it was very stressful. We were stressed about his stress, if that makes sense. So we spent a lot of time, giving sedation before we picked up this bird, and being really, really careful about who was handling the bird and how long we were handling the bird, because we were really hoping for a really positive outcome. So we can kind of go on there. This is a little bit later, that process I was telling you about, catching this bird for repeat radiographs, because, it's great, we do the surgery in here, but that's not the end of the story. The bone still has to heal. We have to make sure it's healed, and we have to ultimately make sure we can remove all those pins and that bar, because they can't go back to the wild with those things. So, that's kind of what we're seeing here is the aftercare. And we can maybe Jess and Rachel can talk a bit about, what did this patient's daily care look like? And what kind of, daily treatments did we have with this patient?
I would say, from my perspective, I think that on a day-to-day basis, he was pretty low maintenance. I think we did the bulk of his, big enclosure cleaning and stuff on his repeat radiograph days, that for the most part, immediately after surgery, that was like a weekly thing, that we were taking those recheck radiographs. And it was usually like on a Tuesday or Wednesday. And I think like Dr. Olivia and I got it down to like almost like an exact science. We would pack up all the things like every single week. And he was a pretty easy keeper, all things considered, especially for being a heron. He ate fairly well, and wasn't too crazy. But every week, I think that, again, because of where the fracture was, it took a lot longer than a lot of fractures normally take to heal, just because it was so distal. So we just had to kind of continue this process for many, many weeks. But ultimately, like it was not terrible. And I feel like we grew to appreciate him even more, just getting to kind of spend so much time every single week doing it.
Yeah, and these photos here, so there's one of him having repeat x-rays, of course, but these other ones are just photos in his enclosure. So we ended up moving this patient outside to an outdoor aviary, even though we still had that fixator and bar on, so that he could do more normal heron things, walk around, eat fish, eat whatever else he might find. And he had a really nice time out there for the most part, I think, which was great. And then I guess I started this by saying, let's talk about some positive outcomes. So, very fortunately, this heron's fracture did heal. There were a few complications along the way, but we got there. And this heron was fortunately able to be returned to the wild. So I think we have a video of that. Yay. Gorgeous. Now, every time I see a heron fly over my house, I'm like, oh, there he is. So it's really, really exciting. Okay, we'll talk about couple other cases, maybe we'll change gears and talk about maybe some wound management type cases. That was a really good example of orthopedic surgery. But we do also see a lot of patients with wounds. Some of them are really straightforward, a little laceration, we just stitch up, we're done, it heals on its own. But others are a lot more complicated, where, there might not be enough skin to fully close that wound. Sometimes we even have to do skin grafts. If there's not enough skin, we can take skin from another place and put it on somewhere else, kind of like a skin bandage, but from the own individual, which is really cool. So the next one I wanted to talk about, let's see if we have any questions actually. Oh, there's a question. Great. Let's answer the question first. It's from Carrie. Does the heterophil act like a marker for inflammatory disease as well? Like if there were many of them, would it signify the patient has arthritis, for example? It does act like a marker for inflammation. Not so much with arthritis, but I worry more about like inflammation with seeing a lot of heterophils. So when we do those complete blood counts, if the heterophil count is high, we might think like, oh, that patient might need antibiotics because they're fighting off an infection, depending what the rest of the clinical picture is. So hopefully that answers that question. So let's talk about some soft tissue surgery or some wound surgery right now. It's another case that I know Dr. Olivia is very fond of. We had this opossum come in. The opossum was in 2023, so it was around this time kind of last year, right, Olivia? And sorry, warning, there are some wound photos here. I should have warned people before we put those up. But do you want to talk about this opossum, Olivia, and let us know the kind of background and what are we seeing here?
Yeah. Again, sorry for these photos. They're a little gruesome, but this is one of my favorite patients ever. This possum came in. He's a very large adult male. He was live trapped. Incidentally, they were not trying to trap this opossum, but these people found him in a trap on their property, and our front desk member Lily brought him back and was like, "This possum looks so bad." And I peeked in, and I was like, "Oh, that's a crazy wound, but I think I can fix it. Like, he's a possum, he'll be fine. I can fix this." And then the students did their exam and they're like, "I don't know about this wound. I feel like his eye doesn't work." And this wound was very old at the point when he got to us. And I think he may have been burned since he also lost his ears. But it was severely contracted. So when wounds heal, they contract to close the defect. But I think the wound originally was much, much larger and had contracted so much it was pulling the skin of his eye, and you can kind of see that skin is really stretched out. So he couldn't really blink, but somehow his eye was still healthy. He never developed a corneal ulcer. His eye stayed moist the whole time. So he's able to adapt to not really being able to blink that eye. So again, prepped this guy with some pain meds and antibiotics and went to surgery a couple days later. This is him prepped for surgery on one side, and then the other side is after surgery. I had to do a whole bunch of moving skin around and kind of interesting things that I had never done before to try to release the tension from all of that contracture. And there was a ton of scar tissue as well. I used some IV tubing, which you can kind of see there, to relieve the pressure of the sutures on the incision. And I had to make a little flap above his eye to relieve tension on his eye so he could maybe blink again one day. But that was a pretty fun surgery. I really like doing wound stuff. And it was a lot of new techniques I got to try out with him. And he was always an excellent patient for it.
Yeah. And wounds can be very, very rewarding to treat, certainly, because, it can go from looking like something very scary to looking completely normal. So I always love wound management. Here's some more pictures of this opossum as he continued to heal. What's on his face in the first photo?
Yeah, so at one point, part of his incision did come undone. Originally, he had an e-collar on, just like a dog or a cat, and we decided, oh, he's fine, you can take it off, and then he opened his incision. So I ended up suturing some Duoderm, which is a bandage that kind of absorbs moisture and holds it there to his face, and it kind of acts like a skin graft a little bit. So that's what you're seeing there, kind of Frankenstein looking, but it's a really nice bandaging material for wound healing, and he's eating one of his mice that he loves.
Yeah, so this patient was with us for a while too. And one of the daily treatments we ended up doing was just putting eye drops in his eye in addition to everything else, because as you could imagine, if you can't fully blink your eye could dry out a little bit. So one of his treatments was simply just eye drops. Many other things as well, but everything is not always complicated, which is nice. So this possum was really, really fun. Also ate very well. We love any animal here that eats well. We are very pleased to have you in our hospital generally, I would say. And this one had a very positive outcome as well. Here's this possum's released. Is it a video or just a photo?
It's just a photo. The video was really long, so I didn't
Yeah,
include
that's
the
fair.
video.
And you were able to release this one, Dr. Olivia?
Yes, I did. I was able to take him for release. I was so excited. He's just from Waynesboro too, so it was not even hard. But as soon as we opened that box, he was sniffing around in the air. I could tell he was so happy to be out of there, even though he did gain a lot of weight from all his snacks that I gave him. But even though this patient would never look normal again, he was functional, which was the important thing. Like, yes, his face looks a little odd, but he was still a fully functional possum and deserved a life in the wild again.
Exactly. And his eye worked normally. He didn't necessarily have really ears anymore, but he could still hear. And that patient did really well. So great. Thank you. Okay, so that's just a couple examples of, really fairly typical stuff we see. Although nothing is typical, it's always different, but things in those streams, wound management, orthopedic repairs, things like that. But there are some more like unique patients will get and try to do surgery on. And we have a couple examples of those coming up next, looking at some amphibians. And people are always like shocked, like, you do surgery on frogs? What? We certainly do surgery on frogs. And we have had lots of really good outcomes actually with our amphibian patients. They're very good healers, especially things like wounds, fractures. We can do all the same things we can do in birds and mammals, really, that we can do in amphibians. So that's really cool. I think we have a picture coming up. There we go. Perfect. So this photo here, it's a very little teeny tiny frog. And this was a green frog from 2023 we did surgery on that had a broken leg. And you can look really, really close and see kind of how we're adapting our anesthetic techniques here. So for our technicians, do you want to tell us a little bit about how do we run anesthesia on a tiny frog like this?
You want me to go? Okay.
You're the expert.
So it's definitely a little different than any other type of animal. Amphibians are very unique. Their physiology is very different, even from reptiles, which they're often like grouped with. I don't necessarily know why, because they're very different creatures. So amphibian skin, they can actually like breathe and drink through it and absorb things through their skin. So we can do a lot of things topically. So we can mix like gel with an anesthetic liquid and apply that, and that will induce anesthesia, for example. So that's really neat. There's a powder that you can put in water that you can use to induce anesthesia. That's actually also used for fish. So that's very cool. But at the same time, you can also use injectable medications like you would for a lot of other animals. And for monitoring, which is a little more challenging than even for reptiles, as you can see in this pickerel frog is sitting on the Doppler probe. And you can actually, so it will pick up the heart rate, the heartbeat. And that's pretty much the only monitoring equipment really that we can use. For monitoring depth, we often will just see, are they moving or not? Are they withdrawing their legs? Are they responding to touch at all? So yeah.
Yeah, no, that's great. You're right. This is a pickerel frog. It's I got it wrong, but this was one that had, I don't know, Olivia, do you remember this one? This one had a broken leg. It was a tibia fracture that we ended up putting a pin in. So just what I wanted to kind of talk about here was the unique challenges of doing teeny tiny surgery. So say, for example, how would we repair a fracture like this, Olivia? Can we use our normal drills and our pins and things like that? Or what do we have to do?
Yeah, so normally for tiny little orthopedic things, we have to put on our thinking caps and see what tiny metal objects that are sterile that we have in the clinic can fit inside that bone. So usually we'll take radiographs and we'll measure the bone and see how big we can fit, how big of something we can fit in there. And then we'll go through mostly our needles and see what size needle might be able to fit in that bone. Often we'll use just our normal little hypodermic needles or even some of our longer spinal needles to do this. And then it is just being so careful because these patients are so tiny and fragile. Both you and I had to do the surgery together just to be able to get that tiny bone. And I just remember trying to find like the inside core, I guess, of the bone to put the needle into. And it was so hard to see because it was such a tiny bone. But one of us had to hold and the other had to advance some needles still. So it was a lot of big hands on a tiny frog.
Yes, and it was we did it though, which is the exciting
Good.
part. This frog, they kind of at some point all blend together in my mind. But when I was prepping for this, I looked it up, and this fracture healed. This frog was successfully released. So really, really exciting that we can, apply these techniques to these big animals like herons and bald eagles, but also these teeny tiny frogs. And gosh, this frog probably didn't weigh more than 10 grams. Was a very, very teeny tiny little creature. And you can see Jess running anesthesia there, and us working on trying to repair that little tiny leg. So really, really cool stuff. We also will use, different techniques where sometimes we can't pin a bone necessarily. Sometimes it's too small. So we had another frog that was even smaller than this one, a tree frog, this little one here. And you can see this tree frog is the size of your finger. It's very little. So in this case, what we did instead of putting a pin in the bone is you can see these stitches here. We stitched the frog's leg to the body so that the frog can no longer extend the leg, essentially immobilizing the leg so the bones could heal. Because we can't put a splint or a bandage or anything like that on this teeny tiny frog. And that was very effective as well. So it's a lot of creativity, a lot of trying different things, sometimes trying new things. This was, I think, the second time we had done this. And it works, quite well, but it's not something that's in a textbook or anything like that. So it's a lot of innovating in the field we're in, which is pretty cool. But we also see wounds and things like that in our amphibian patients as well. As I mentioned, this is a really special little patient we had that had a wound on the elbow that we had to close surgically. Rachel, do you want to tell us about this one? I know you were a fan of this one.
Yes, so this was an eastern spadefoot who came in last year, and he was dug up in a garden. So these frogs are they spend most of their lives underground in burrows, so they're rarely seen. So it was very exciting just to see one, first off. So yeah, he had a wound on his elbow that Dr. Olivia and I helped with the anesthesia. Dr. Olivia went in and put some sutures in. And he healed very well. I think we had to redo it once. I believe it opened once. But then I think he was only with us for a couple weeks to a month. And then Dr. Marie and I were able to go release him. He was from Waynesboro.
Super exciting. And that does bring up a good point that sometimes we have to revise our surgeries more than once. It doesn't always go as well as you think it will go the first time. And also our patients present some unique challenges that, with your dog or cat after they have surgery, you can crate rest them and tell them it's, give them a feeder puzzle or something to distract them. With our wild animal patients, we can give them sedation and things like that. But ultimately, they're wild animals and they do wild things and get into all sorts of predicaments, even in care that you could not possibly imagine. There's been many times where there was a hawk we had a couple weeks ago that, I did the orthopedic repair. I was very pleased with it. It looked very good. And then that bird everything was removed. He removed it all himself. So things go wrong, certainly in some instances. And sometimes we have to revise and revise and revise to try and, get that patient through our care. So very cool. I also wanted to talk a little bit about something Jess touched on earlier, which is, sometimes there's surgeries that are beyond our skill level, right? We all, do the best we can, but there are out there in the world veterinary surgeons who are specialized just to do surgery. They've done a residency just to do surgery the way we have studied just to work with wildlife. And sometimes we have to reach out to those partners for help and collaboration. And an example of that was that bear cub Jess showed a little earlier. And I think we have some more photos again. This was one of our 2022 bear cubs that had a fracture, and the fracture was of the forelimb, so the front leg, and it was really, really close to that elbow joint. If you watched any of our bear cams, you know that they're climbing trees, they're digging, they use those forelimbs for so much, right? And how close that fracture was to the joint. I was really worried that, if this wasn't repaired perfectly and the first time, arthritis could develop in that elbow that would prevent that cub from being able to be released to the wild. So with that, we reached out to a specialist in Charlottesville. I sent them the x-rays and was like, just, please, would you help me with this? It's a tiny, cute baby bear cub. I think I probably sent them a photo to try to win them over. But as you can see in the photo, this cub was really little. It was certainly more than I felt we had the capability and the skills for here. And fortunately, the specialist in Charlottesville responded pretty immediately, and we're like, oh yeah, this sounds very cool. We're very, very happy to do it. So one day, Jess and I packed up this bear cub, and you can see her in the photos there, and we drove to Charlottesville with this little cub, and our little cub had surgery in the small animal specialty hospital. It's always, very, very challenging in these situations. We've done this a few times, and, you roll into this place where there's 30 staff and say you have a bear cub, and you get a lot of attention immediately. But we also have to remember we're still wildlife. We're just working with wildlife. We can't let people see the bear cub or hold the bear cub or, look at the bear cub while it's awake. So it's one of those things where we go in kind of as the guardians, being like, I'm so sorry you can't see it. I'm so sorry. Please don't talk. And then, once the patient's under anesthesia, like you see in that photo there, then we'll have, the other staff around and able to help prep for surgery and monitor and things like that. But it is very much like Jess and I are the guardians that are like, nope, so sorry. And it always is, a very interesting experience. But Jess, what do you remember about the surgery and that day, and how did it go?
I just thought it was so lovely to work with like the staff from that facility. They were just so kind, and especially I just remember the technician that we worked with there. I mean, in the grand scheme of things, I think that we don't really do a ton of like general anesthesia on like large mammals. And that's something that I feel like, in my skill set, I think that I for sure am lacking in that area. And so it was just funny because I remember specifically when we were doing like the preoperative care for this bird or this bear. I'm even saying bird just because it just rolls off the tongue naturally. We were struggling to place the catheter, and I was like, oh my God, this is like something that I never do. And we like tried a couple times, and then we had the tech that was going to be running anesthesia for this bear come in, and she just placed it immediately on the first go. And I was like, yeah, this is clearly something that I don't do every day. So it was funny, but everything went really smoothly, and everyone there was just like so incredibly sweet. And it was nice to see like two teams coming together for, a common cause. So
yeah. And they actually were able to put a plate in this bear's or humerus. So they put a plate with screws on, and that went in that bear and has stayed in that bear. You can see the bear is teeny tiny at this point. So the plate that went in, well, that bone was healing, was only about this big. And the surgeon was, after he was like, how big will this bear be in the future? And I told him, and if anyone ever sees this, like if anyone ever like hunts this bear, or it comes back in for some reason, they were going to be like, what were they doing? Why did they put this 2-inch plate in this bear? But the reality that they grow really fast. And this bear did really well and recovered really well. And I think we have one more cute photo of him standing in his little splint, but that healed really, really well. And we did recheck radiographs a couple times, and then at release as well, we double checked this, and everything was completely fine, completely normal. The elbow moved perfectly. So this is a really good example of kind of collaborating for a really good outcome, which is kind of cool. Oh my gosh, we're running out of time. Okay, a couple more cases I wanted to touch on, and then we'll finish up here. The next one I have a few photos of is a patient we actually took to the same specialty center for help. And this was a golden eagle that came in back in 2023. And we had this golden eagle come in with this mass or this swelling on the face. And we couldn't figure out necessarily what it was. And we drained it. We did a bunch of different tests. And then ultimately that same specialty center performed a CT scan for this patient. And we were able to see it was like infection tracking all through the face. So here's just a picture of the eagle in the CT, which is pretty cool. So at that point, we kind of realized this was an infectious mass, likely fungal in origin, that we would need to surgically debride and remove. So it's just a few photos of the surgery here. Dr. Olivia and I trying to remove this. And this is just, I wanted to include this because it was a cool case for sure. But things also don't always go as well as, you hope they will with every patient. And this patient, we did surgery, we removed as much as we could. But again, with a fungal infection systemically, this patient was not very well. And this patient did not survive to release. So we had a lot of really positive outcomes, but the flip side of it is our patients don't always make it through, the surgical procedure, or maybe they make it through the surgical procedure, but then they don't make it to release. So it's not always, yay, we did surgery, we saved them. We hope that's the outcome, but it certainly always isn't, unfortunately. So Jess, do you have anything to add about this eagle? I know you came with me to do the CT, but
I just remember it was like again, we worked with that same organization, and it was just like everyone crowded around. It was nice because the CT scanner kind of had like a viewing window that's similar to like our surgical suite. So everyone could kind of like watch this eagle being put under and having the CT scan done. But we get so few golden eagles. I think that was another reason why this patient resonated to me for being like so special. It was just a very unique, interesting case, I thought.
Very cool. Awesome. Okay. Well, the next point I want to touch on is we are a teaching hospital. Here's Dr. Natalie. I'm learning right now. And we teach a lot of these surgeries as well. So there are more advanced things we try and we do, but there is stuff we do commonly that our interns get to learn to do. And one example of that is a really fun surgery we do not uncommonly in Eastern rat snakes. So I will let Dr. Natalie tell you about this rat snake patient and what this patient has done to need surgery. So go for it.
So this Eastern rat snake came in on the 4th of July. With a very large swelling in the middle of its body. It had been found in someone's chicken coop and had eaten likely one of the ceramic eggs that was in the chicken coop. And we've seen several this year, some prior to this snake and some after this snake. And just like in dogs or cats, when an animal eats something, a wild animal eats something that can't be digested, such as a ceramic egg, you have to go in and retrieve it. So here you can see Dr. Karra and I in surgery with this snake. Just like in dogs and cats, they have a digestive tract that has multiple layers. And so you have to get through the skin, down into the body cavity, through the body wall, and then into the actual digestive tract itself. And then retrieve the object. The most fun part about this surgery was the happy little surprise that we got when we actually removed the egg from our patient. And you can see us, working to get the egg out in these two images. But what we weren't anticipating was a little smiley face coming out as we removed this egg. So you can't see the smiley face particularly well in this photo, but I believe, Rachel, you still have this egg, is that correct?
I kept it.
And we have it here today just for fun. Some of the objects
Actually, there were 2 eggs too.
yes.
This one
So
has
this was the
2
first
eggs.
egg that was pulled out, and came out face first.
I don't know if you can see it.
Oh yeah. Yeah, we can move it over a little. Perfect. Yeah.
That was a fun surprise for us. Usually the ceramic eggs do not come with smiley faces. And I distinctly recall asking Dr. Karra why there was a face coming out with the egg, and we all got a good laugh out of it.
Yeah, it's definitely the first time I've seen that. I've seen this surgery a lot and done this surgery a lot. We also see it like wooden eggs, golf balls. Snakes like to eat golf balls as well, thinking they're eggs. They're not. But I've never seen them with a smiley face on it before. So that was a fun surprise. But that was the second. So you saw one when you first started, right? Then we did that one together. And then more recently, Dr. Natalie did that same surgery all by herself, because, we're a teaching hospital. So I was like, she's like, are you going to scrub in with me? And I was like, I'm not. I will be out there if you have any questions, but it's time for you to do it on your own. And she did a great job, and that snake is still here, and doing very well. We'll have to overwinter that snake at this point because the seasons are changing rapidly outside. It's very cold in Waynesboro today. But that's just a really good example of, the progression our interns go through to learn these procedures, and have these patients, return to the wild, which is really, really neat. I think we pretty much have all done this surgery at least once or twice by now. And it's always a very fun surgery, very rewarding. The students always get very excited about it too, because it's just, something you can fix, and something that is kind of funny a little bit, I think. So, I think our photos went down now, but that's okay. We haven't really talked much about snakes though. We have a couple more minutes. From our technician's perspective, are there any special challenges with snake anesthesia, or what are the things you think about with running snake anesthesia?
Yeah, I think snakes definitely do present a challenge for me anyways. I feel like they're just kind of a mixed bag. I think reptiles in general are more challenging than birds and mammals. They're just harder to read in terms of like their reflexes and the normal things that you would typically check when you're trying to assess their anesthetic depth. Snakes love to do this thing where, we'll in terms of like their preparation, we'll get them ready, get them intubated, everything will be running smoothly, and then your surgeon goes to cut or does something that's very stimulating to the snake, and then all of a sudden they're awake and then they're very reactive. And so that's a lot of fun, but the normal reflexes that you typically check in a snake or like a lizard or something is something called a righting reflex. So if you flip them over so that they're on their back or something, if they're awake, then they'll right themselves so they're right side up. And so that's like a really good indicator, of depth in snakes. And snakes are just they're really difficult with anesthesia. They're just awake and then they're asleep. It's hard to manage sometimes.
With reptiles in general for surgery too, they just do everything so slowly, that they go to sleep really slowly, they wake up really slowly. I have fond memories from when I was an intern here, being here at 11 o'clock at night, waiting for a snapping turtle to wake up from surgery. Everyone had gone home, but the turtle wasn't awake yet and wasn't breathing on its own yet, so I had to keep giving breaths to it. And it was 11 o'clock. I was sitting in this very room with my computer, working with one hand, breathing for the turtle with the other hand, because they just take so much time. Okay, I think we are getting near the end. My gosh, that went fast. I'm trying to think if there's any other like funny stories to share, and I certainly have one. That was Jess and I were doing surgery on a raven in this operating room. And I like to listen to music during surgery. So I usually have my phone over there somewhere, just like quietly, usually playing Taylor Swift. And I had my Apple Watch in my pocket. And I guess somehow, I don't know how, I leaned on my watch and called 911 with my watch during surgery. So my phone was sitting over there playing Taylor Swift, and Jess was like, hey, the police are calling you. Should I answer? I was like, well, yes, I guess. She's like, it's 911. 911's calling. And I was like, oh yeah, I guess we'll answer. So she answered, and it was the police dispatch, calling to see, you know, if why I called 911. And Jess kind of tried to explain the situation. And I was like scrubbed in, sterile in surgery. And they were like, no, we need to talk to her to make sure she's okay, which is, you know, their protocol. They need to talk to the actual person who called to make sure there's not actually a distressing situation. So I'll never forget like having my hands trying to fix this raven. My hands are sterile. Jess is holding the phone to my head while I'm trying to explain to them, I'm so sorry, I pocket dialed you. I'm doing surgery right now. It was just very embarrassing. And now I never, ever, ever will put my watch in my pocket, ever since then, because I don't want to do that again. That's a one and done, hopefully, situation. Does anyone else have any, and we have like 1 minute left. Oh my gosh, any additional like comments, or are there any questions in the chat that someone could send through to me if there are any that we could answer? I answered the one, but I haven't seen any others come through.
If there's no questions, I forgot I still have the Herod's
Oh yeah.
fixator. So this is about the size of his fixator. And I don't know if you can see, there's one pin that's still intact. So this was in his bone. It was very close to his skin, so it's very hard to cut. So I ended up just unscrewing it at the end. But this is what his fixator looks like. It's an acrylic bar. And there's the putty that we actually use to fix turtle shells is on there to cover up the sharp ends, since we weren't going to be picking him up every day.
Cool. No, thank you. I'm so glad we brought props to this.
We're a very show and tell heavy
Yeah.
type of group.
Definitely. Well, I think we'll leave it there then. And hopefully everyone learned something. I had fun at least, so that's something. And thank you to everyone for making time to do this. We'll say goodbye and run back into the clinic to see if there's any new surgical patients potentially. Awesome. All right.
Bye.